Board meeting by Governor Newsom to serve in the direct care provider role. I am also the current president of the board. Vice President Mary Fagan.
Good morning, everyone. I'm Mary Fagan. I am the Vice President of the Board of Nursing. I was appointed by Governor Newsom in the Nursing Services Administrator role.
Board Member Jovita Dominguez.
Good morning, Jovita Dominguez, appointed by Governor Newsom and Chair of the Education and Licensing. Good morning.
Board Member Patricia Nguyen. Board Member David Lawler.
Good morning. I'm David Lawler, appointed by Governor Newsom in the public member role.
Board Member Vicki Granowitz.
Vicki Granowitz, public member appointed by Tony Atkins, Senator pro tempore.
Board Member Allison Cormack.
Good morning, Allison Cormack. I was appointed by the prior Speaker of the Assembly in the role of public member.
Board Member Neelu Patel.
Good morning. My name is Neelu Patel. I was appointed by Governor Newsom for the advanced practice role, and I'm also on the committee for the Legislative Committee.
Board's Executive Officer Loretta Melby.
Good morning. My name is Loretta Melby, or Lori, and I'm the board's executive officer appointed by the board.
And Board Counsel Reza Pejjuhesh.
Good morning, everyone. Reza Pejjuhesh, attorney with the DCA Legal Affairs Division and BRN Legal Counsel.
Thank you. Quorum has been established for today's meeting. We will move on in the agenda. We will pick up from where we left off yesterday on item 10.0. This is the report on legislation. This is my committee, and I have Marissa Clark that will be reporting out.
Good morning, everyone. Marissa Clark, the Chief of Legislative Affairs. So the first bill we're jumping back into today is AB 2200 by Assemblymember Kalra. I'm going to start again with a little bit of background just to provide some context on past efforts, and then I'll go into the bill. So over the last decade or so, California has had several attempts at legislation to establish a universal healthcare system. Three of the most recent legislative successes were AB 1810, SB 104, and SB 770. So passed in 2018, AB 1810 created a 5-member council on healthcare delivery systems to write a plan to provide California residents with universal healthcare coverage. The charge to the council was to make recommendations to the governor and legislature regarding steps needed to achieve access to healthcare for all Californians through a unified financing system. The next year, SB 104, passed in 2019, revised some of the provisions of AB 1810 and changed that 5-member council on healthcare delivery systems to a 13-member Healthy California for All Commission. SB 104 charged the commission with developing a plan that includes options for advancing progress toward achieving a healthcare delivery system in California that provides coverage and access through a unified financing system, including but not limited to a single-payer financing system for all Californians. So there's a lot of issues debated by the commission, and one of the main ones that came up was how to draw down the federal dollars that are currently being spent on healthcare in California. The commission's report found that unified financing could not be accomplished in California without some level of federal support. However, there was a bit of a disagreement about whether federal participation could be accomplished through existing waiver authority or whether a change in federal law would be required. So fast forward a couple years, just last year, Senate Bill 770 passed in 2023, directed the Secretary of the California Health and Human Services Agency to research, develop, and pursue waiver discussions with the federal government with the objective of a unified healthcare financing system that incorporates specific features, including a comprehensive package of medical, behavioral health, pharmaceutical, dental, and vision benefits without cost sharing for essential services and treatments. The bill requires the Secretary to provide an interim report by January 1, 2025, detailing the agency's preliminary analysis and input from stakeholders, and to propose statutory language authorizing the development and submission of federal waiver applications. The bill then requires the Secretary to complete the waiver framework by June 1, 2025, and hold a 45-day public comment period and produce a report on the finalized waiver framework by November 1st, 2025. So next we'll go into the proposed bill. This is a kind of broader impacting the field of nursing as a whole. Obviously, it's a very large proposed change and it's a very complex bill. So I'm going to touch on just some of the key provisions in each section. More information can be found in the bill analysis and then obviously in the bill language itself, because it is a very detailed bill. So I'll just go through some key items in each section and then open it up for questions and discussion. So the first section is on governance. The bill would establish one main governing body, the CalCare Board. It would be an independent state entity charged with establishing and implementing the CalCare program. The bill would also establish 3 advisory committees to the board: the CalCare Public Advisory Committee, an advisory committee on long-term services and support, an advisory committee on public employees retirement system health benefits. And the bill states that no later than 2 years after the effective date, the board must accommodate the accrued benefits of retirees living out of the state and reconcile obligations with the workers' compensation system. The bill would require the board to provide funds to the Secretary of Labor and Workforce Development for program assistance to displaced health insurance workforce. And the bill would require the board to conduct a fiscal analysis to determine whether CalCare may be implemented and has the revenue to fund the costs of implementation. So the next section touches on eligibility and enrollment. The bill requires every resident of the state to be eligible and entitled to enroll as a member of CalCare and prohibits the requirement of any charge, any premium, or any cost sharing. The bill would also require the CalCare Board to establish a process for automatic CalCare enrollment at the time of birth in California. The next section touches on benefits. So the bill states that enrolled CalCare individuals are entitled to have healthcare items and services paid if medically necessary or appropriate for maintenance of health or for the prevention, diagnosis, treatment, or rehabilitation of a health condition, and that determination of medical necessity or appropriateness is to be made by the treating physician or appropriate healthcare professional. The bill also states that Californians will have access to comprehensive healthcare benefits that are not subject to prior authorization or limitation applied through the use of step therapy protocols. Next section talks about delivery of care. And the bill states that a healthcare provider or entity is qualified to participate as a CalCare provider if they furnish healthcare items and services while physically present within the state of California, and if the provider meets all of the following. The provider or entity is a healthcare professional, group practice, or institutional healthcare provider licensed to practice in California. The provider or entity agrees to accept CalCare rates as payment in full for all covered healthcare items and services. The provider or entity has filed with the board a participation agreement, and the provider or entity is otherwise in good standing. Under the bill, a healthcare provider would be required to enter into a participation agreement with CalCare in order to receive payment for items or services. And the participation agreement would contractually obligate the provider to follow all CalCare policies and procedures, furnish information reasonably required to meet reporting requirements, and other reasonable disclosures. The bill also states that providers are not allowed to enter risk-bearing, risk-sharing, or risk-shifting agreements with healthcare providers or entities other than CalCare. So next section is the payment for healthcare items and services. The bill requires all payments under CalCare to be reasonable and reasonably related to all of the following: the cost of efficiently providing healthcare items and services, ensuring availability and accessibility of CalCare healthcare services, including compliance with state requirements regarding network adequacy, timely access, and language access, and maintaining an optimal workforce and the healthcare facilities necessary to deliver quality, equitable healthcare. The bill requires an institutional provider's global budget to be negotiated with CalCare on an annual basis and then paid via lump sum on a quarterly basis. The bill would require existing Medicare prospective payment systems to serve as the comparative payment rate system in those global budget negotiations. The bill states that group practices, county organized health systems, and local initiatives may elect to be paid on a salaried basis or a fee-for-service basis. And the bill requires the CalCare Board to engage in good faith negotiations with healthcare providers to determine fee-for-service payment rates annually with a rebuttable presumption that Medicare fee-for-service rates constitute reasonable payment rates. And the bill would also require the board to negotiate prices to be paid for pharmaceuticals, medical supplies, medical technology, and medically necessary assistive equipment. Next touches on the program standards. The bill requires the board to establish a single standard of safe, therapeutic, and effective care for all residents of the state. The bill would require the board to coordinate with other state agencies to monitor for participating provider compliance with CalCare program standards and establish programs that ensure CalCare member access to quality in-person, primary, and preventative care. And the bill would also prohibit certain types of financial interest and bonus payments for providers and require providers to report financial interests or relationships with other providers to the Department of Healthcare Access and Information. Next is the funding section. So the bill authorizes the board to seek all necessary federal waivers and approvals to receive federal funding for healthcare items and services to be used by the CalCare program and requires the board to apply for those waivers by January 1, 2026. The bill establishes the CalCare Trust Fund in the state treasury, and it would consist of state and federal funds for healthcare services. And the bill also establishes the intent of the legislature to enact legislation that would develop a revenue plan that takes into consideration anticipated federal revenue available for CalCare. And then the last section is on the transition. So the bill requires the board to ensure that all persons enrolled or who seek to enroll in a health plan during the implementation period are protected from disruptions in their care during the implementation period, including the continuity of care with current healthcare teams. The bill requires the board to provide funds to the Secretary of Labor and Workforce Development for programs to address healthcare workforce education, recruitment, and retention to meet healthcare workforce demands under CalCare. The bill also establishes a health workforce working group to provide input, including recommendations to the board and the Secretary of Labor and Workforce Development on issues related to healthcare, workforce education, recruitment, and retention. And then lastly, the bill has a provision that states the program shall not become operative until the Secretary of California Health and Human Services determines that the CalCare Trust Fund has the revenues to fund the costs of implementation. So again, that was just a touching on some of the kind of key points of the bill. I know there was a lot there, but I'm happy to open it for any questions or general discussion.
Board Member Neela Patel.
Hi, good morning. That was great analysis. There's a lot of information here. Do you see that with this CalCare working towards the healthcare workforce education, do you see it as an avenue to promote education in the state colleges and the junior colleges, just to, increase opportunities for nursing programs to have, graduate students?
Yeah, that's a great question. There is actually a provision under one of the working groups, and let me pull it up so I'm quoting it correctly, where one of the issues they do talk about studying is nursing program capacity and clinical placements. And I believe that is. Yes. So it talks about under the program standards, the board will establish requirements and standards and then by regulation. And one of the things in the standards they would talk about would be clinical placement for educational purposes, including clinical placement for pre-licensure registered nursing students without regard to degree type that prioritizes nursing students in public education programs. And then they also talk about the CalCare CalCare Health Workforce Working Group. One of the things they would be charged with discussing is programs and measures to expand clinical education capacity at California community colleges to provide associate degree programs in health professions. So there is some talk about increasing the capacity around that particular avenue. Mm-hmm.
Any other questions or comments? Board Member Vicki Granowitz.
Yeah, they've been trying to get something like this passed for a very long time, universal health care. And so it feels like in an attempt to try to do something a little different, they've thrown in this last section to see if they can't get some support from some groups that are maybe not as political, but it pulls us into something that to me feels more political. I mean, I know what my personal views are on universal health care. But when I think about us taking a position, I just think we need to be mindful that when I look at this, it's like, you know, what's different about all the sections? And this last section just feels different to me than all the previous sections. And so I'm just a little,
Are you speaking of the funding or transition?
the workforce working group, where they're talking about the education. Like all the rest of it is all about funding and what's going to be covered and who's going to be covered and the transition. And there's some sections on optimal workforce, but it almost feels like that's kind of thrown in. I know you're frowning at me.
Huh?
I can see you frowning at me.
Oh, no, no, I was listening, sorry.
Well, it's just the perspective that it felt like that section seemed a little thrown into me, you know? Like, why not a working group on how you would administer this thing or how you get people to support it? But, you know, the workforce thing, I sort of don't get why that's in here.
Well, I think I could shed some light on that, because when you're dealing with insurance companies, like we have some laws here under CMS. And CMS has a provision right now, 413.85, cost of approved nursing and allied health education activities. And so it requires hospital settings to provide clinical education to nurses, to physician assistants, to physicians. So this is actually consistent with current law with CMS. But it's not typically something that we would probably discuss as part of the Board of Registered Nursing because we don't have any jurisdiction over CMS and payment and billing and such. So when we're bringing a bill forward like this and you see provisions for clinical practice, you're kind of like, well, why? And that's because it is currently in law already. And so it's just expanding on that. So when we're dealing with CMS, one of the sections right here talks about Medicare payments and your reimbursement. And some of that is based on whether or not they're able to, like here, classroom instruction costs or the costs associated with formal didactic instruction, specific topics. And so those, it goes on and on and on as part of CMS.
The only pushback I would give you on that is that at least when you're dealing with workforce and unions in San Diego, everything is meet and confer. And this would so substantially change our healthcare that you're going to have huge issues dealing with the workforce that this little section can't really begin to touch. So whether it's in law or not, this would so substantially change everything that this little section here just seems inadequate to do what you're talking about. So I still am a little suspicious.
Lars? Board Member Patricia Nguyen.
Oh, sorry, I messed up, sorry. Has the BRN taken positions on these, universal healthcare bills in the past?
Not to my knowledge in the recent past, like for example, the one last year, this one does actually name the BRN in a small kind of few provisions when it talks about the working groups consulting with the BRN. So we are named in a way that we haven't been in the past, but we didn't weigh in on SB 770 because it was a separate agency. And then prior to that, I don't believe so. We'd have to check records, but not to my knowledge.
Well, just from my point of view, I would just say this feels a little premature It's a huge bill. It's probably going to go through a number of iterations. It feels a little premature for us to be weighing in, but I'd love to hear, the thoughts of other committee members.
Board Member Neela Patel.
So it's great to hear your perspective, Vicky. And just in general, I think one of the things that really reassured me of this particular bill was the fact that they do address workforce, especially education, because I think that is the key really, right, to providing care for a greater population of people in our state. So I'm glad that it does at least touch on that. So hopefully they do expand on it as we go forward, but I'm glad to see it there.
Board Member Allison Cormack.
Thank you, Chair Trujillo. Okay, so the CalCare Board would have very broad responsibilities, and it's described as an independent public entity. Does the bill state who would constitute the board and who would choose the members?
Yes, there are in the bill language, I believe in the analysis, there's a little bit of a summary around the members, the seats they would have to fill, and who their appointing authorities would be. And that, I can pull that up right now. There's also, it's spelled out for the various advisory committees as well.
I may have missed that, but on page 15.
Oh, sorry, you're right. That one was, I was trying to, for the sake of brevity, trying to pull out certain things and then keep others when there was long lists, but that's a fantastic question. So for the CalCare Executive Board, the appointments to the board shall be made as follows. It would have 2 healthcare professionals who practice medicine, at least 1 being a practicing physician or medical doctor, 1 registered nurse, 1 public health professional, 1 mental health professional, 1 member with an institutional provider background, 1 representative for a not-for-profit organization that advocates for individuals who use healthcare in California, 1 representative of a labor organization, and 1 member of the committee established pursuant to section 100611, which is the Public Advisory Committee. And it states that the appointing authorities, 5 shall be appointed by the governor, 2 shall be appointed by the Senate Committee on Rules, and 2 shall be appointed by the Speaker of the Assembly. And then the Secretary of California Health and Human Services or their designee would serve as a non-voting ex officio member of the board.
That's helpful information. So now on page 17, I mean, the biggest, there are many barriers their society faces if we decide to move to this form of healthcare delivery. And the biggest has traditionally been financing. Am I right that on page 17, the top where it says they have to deliver a fiscal analysis about whether or not this can be implemented and if revenue is more than likely to be sufficient to pay for, I mean, this is a really big part of their job. Am I?
Correct.
Okay, so that's their big job. And when would that be due?
I don't believe there is a deadline. So there's a couple different components that talk around the funding. I think there's the one aspect of the federal waivers and figuring out how to
Right.
kind of consolidate and draw down, which I think.
And that had a deadline, yeah.
Yes, correct. And I think that accounts for like 40% or so of the money currently we spend. And then there's also a provision in there under the funding section around the legislature creating a plan to fund it.
Right.
There is not a deadline in there for that. But then there is an operative clause that essentially says it's kind of like a trigger that none of the program will be implemented
Right.
until. So I would assume that operative clause and that revenue plan clause would kind of work hand in hand. Which one would kind of come first? But I think it's assuming that more discussions around that state funding piece would come down the road.
Okay. And then on page 19, I want to be sure I understand this. The bill requires an institutional provider's global budget to be negotiated with CalCare on an annual basis. So is an institutional provider like a dentist and a dental hygienist? It's a hospital, it's anyone that's more than an individual?
Typically like a hospital, a skilled nursing facility, an organization like that is the examples they gave in the bill.
Okay. All right. I mean, obviously lots to do. I'm aligned with Board Member Nguyen on, not taking a position at this time. Thank you.
Any other questions or comments from the board? Okay, we'll take it to a motion. I would like to motion that we support this bill. And I'm saying this because overall, you know, the general public has had, many people are without health insurance and without health care. And for us to get into the weeds of how it's going to be financed, I think that will come along later. But for now, the overall premise is that I support this bill for what it stands for, and that's healthcare for all.
I
And
second,
I-
David.
Thank you, David. Can we now go out for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give them a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Mari Lopez would like to make a comment. 1 second, please. Go ahead.
Thank you. Good morning, everyone. My name is Mari Lopez. I'm a legislative advocate with the California Nurses Association. The CNA is the proud sponsor of AB 2200 and strongly urges the board support. This bill updates and improves upon previous bills on single-payer healthcare. And everyday nurses witness preventable healthcare tragedies that result from our current fragmented, profit-driven system of insurance. The bill establishes CalCare as a single publicly run, publicly financed system of comprehensive guaranteed health care for all Californians. Under CalCare, providers as well as patients would spend less time, money, and resources navigating a web of insurance systems. And nurses would have more time to do what they do best, which is care for patients. Nurses could provide care based on your professional judgment without insurance corporation interference, resulting in better care. Notably, in this CalCare bill, there are new provisions on healthcare workforce and health equity. Last session, the Assembly Health Committee asked for more detail on how CalCare would address healthcare workforce needs as demand in healthcare services increase. And addressing these questions, the new bill includes robust provisions on healthcare workforce recruitment and retention, both during the transition to CalCare and in the long term. These provisions aim to ensure that California nurses have safe staffing levels while caring for California's patients, and aim to support medically underserved areas. There are many elements of AB 2200 that would support nurses in your practice and in protecting your patients. And with that, we urge that BRN support this bill. Thank you so very much.
Thank you for your comment. Board President Trujillo, there are no public requests for comments on the WebEx. Are there any public requests for comments there in Sacramento?
No, there is not.
Would you like me to close this window?
Yes, please. All right, we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan, no.
Board Member Jovita Dominguez.
Jovita Dominguez, yes.
Board Member Patricia Nguyen.
Win, no.
Board Member David Lawler.
David, yes.
Board Member Vicky Granowitz. Board Member Allison Cormack.
Cormac, no.
Board Member Neela Patel.
Patel, yes.
All right, I believe we're split.
I counted 4 noes, and there's 8 of you. So I believe your motion failed.
Yeah, 4 and 4. All
And
right,
Mary, Tricia, Vicky, and Allison as noes.
okay. Board Member Patricia Nguyen.
I do hope that we will bring this back next board meeting and let us take another look at it, because I do think there's a lot of promise in this bill. I just am not comfortable right now supporting it. Thank you.
Okay, any other questions or comments before we move on?
I will also share the CMS guidelines for you guys as well. That's done at a federal level so that you can see kind of a comparison because I know that not many people are familiar with some of those guidelines and so see how this aligns, sorry. So I'll share that out.
Okay. So the next bill is a pretty short and straightforward one. It's AB 2270 by Assemblymember Mainshine. And quick background, the board requires all licensees to complete 30 hours in continuing education every 2 years to maintain their active license. And all the courses must be taken through a continuing education provider that is recognized by the board. So this bill would require Healing Art Board licensees to have the option of taking coursework on menopausal, mental, and physical health to satisfy continuing education requirements. And that is the bill.
Any questions or comments from the board? Oh, yes. Board Member Allison Cormack?
Are these courses not currently available as continuing education options?
I believe they are. Technically, I don't think we would need this bill in order for
That
for
was
them
my-
to have to
that
take
was
them,
my
essentially.
question,
Yes.
right? This
Yeah, no
is-
prohibition that.
There's
is
not,
currently-
these courses already exist. They can be taken for people's continuing education.
So
Thank you.
both of these continuing education bills put forward by the same author really would have zero impact on the California Board of Registered Nursing. The way that our continuing education provider and information is set up is that you must, as an RN, take classes that are above what you would take to prepare yourself for licensure. So all the pre-licensure content doesn't count, but anything post-licensure, anything after that would count. Even the continuing education provider information, it doesn't have to be a specific person or a specific entity. We do approve those, but we also take in other nationally recognized organizations that can give continuing education. And there is very small amount of stuff that is actually prohibited for our nurses to take as a continuing education course. And those are look for like personal gain kind of stuff, financial stuff, that would not count towards continuing education. So both of these items that are being covered in the bills do have zero effect on the board, but we could go ahead and add that in. And there are some things when you look at our statute that are around continuing education where they say, make sure you add implicit bias, make sure that you add domestic abuse, make sure that you add those. And so this here just kind of says, make sure to add those in or include those or consider those, and it might help get the word out, but it's not going to change our process.
Okay, when you say be sure to add those, that's, we tell nurses be sure to add this, or that's telling the board be sure to have it included?
We have one section where we say you do add, and that's the implicit bias. The other one's section, and I can read it for you here real quick, and it's kind of,
Like things to consider type thing?
yeah, and it's buried under a oddly named section. It's Article 6, and it's under revenue. And so it talks about continuing education, and it says that, sorry, the board shall encourage continuing education in spousal or partner abuse detection and treatment. And so it's encourage, not require. And then the other one talks about where you must have the implicit bias. And so these are some of the things that if this bill were kind of to morph a little bit, it might fall under that section as well. But in our California Code of Regulation, where we went in to say what is acceptable for continuing education courses, what we have right now, it's courses related to the scientific knowledge for the practice of nursing, including basic and advanced courses in the physical, social, and behavioral sciences, as well as advanced nursing in general or specialty areas. Content which includes the application of scientific knowledge to patient care in addition to advanced nursing courses may include courses in related areas, i.e. human sexuality, death, dying, and grief, foreign language, conversational, therapeutic interpersonal relationship skills, pharmacology, generally accepted experimental medical procedures or treatments, and those related to specialty areas of nursing practice. Courses in nursing administration, management, education, research, or other functional areas of nursing related to indirect patient care, client care would be acceptable. And then it does have the clause that says courses which deal with self-improvement, changes in attitude, financial gain, and those courses designed for the lay people are not accepted for meeting requirements for licensure renewal. So if this were to pass, we could put into our regulation that says menopause or mental health, reproductive, we can add those in so that it's kind of more of a reminder or a knowledge if someone were to go there, but it's not going to change how we currently operate because those are inclusive.
Is there anything preventing the BRN from writing a more comprehensive paragraph already?
We just updated these last year. And we have a current in 1452, which is also continuing education right now that is with OAL. And so we're constantly updating. It wouldn't prohibit us from doing it, but when you become too prescriptive, too robust, it kind of gets
It
stumbly.
diminishes the
Yeah.
impact. Yeah. Okay. Thanks for that.
Board Member Vicky Granowitz.
I could see that there is a possibility of people just adding on and adding on and adding on. And so I think it's kind of unnecessary based on what Lori has said. And so when I read this one and I read the other one, they both felt like somebody was trying to speak to a population to show that they were sympathetic to a particular group, but it didn't feel like it was going to actually add to our mission. And if anything, it would sort of muddy up and create a spiral. So I wouldn't support this one or the other one.
Yeah, so these two bills right now, and Marissa, I'll let you kind of jump in as well. They are very hot topics in healthcare right now. There is not a lot of information out there within the healthcare community on menopause, on maternity, mental health, et cetera. And so these do draw attention to that. So I definitely kind of see where that falls in. But when you're looking at implementing this, it's unnecessary for us, but it's not just a bill that's specifically written for us. It is written for other Healing Art boards as well.
Correct. And also just a general kind of disclaimer, it is really tough at this early point in the session to know which bills are fully baked and which ones aren't, because the deadline did just come. So I'm not sure on this. I did reach out to see if there's a fact sheet just to try. It's a very busy time, obviously, but there is always the possibility that it was like a bill in this area is intended, and this is kind of the step in as the language gets fleshed out. I don't know that for sure, but that is something that I struggle with as I'm doing analysis and trying to figure out like which one of these are like, okay, this is really the direction we're set on, and which one is kind of, okay, we're moving and it's evolving type of thing. So I just put that as a disclaimer if that could be a possibility. I don't know whether it is or not.
And it's also possible that Assemblymember Mainshine won't even be around to continue this because he's running for city attorney in the city of San Diego. So I don't know if there's somebody else that would want to continue to cheerlead for this, but just interesting tidbit.
Dolores.
Neela Patel.
Board Member Patel here. I'm glad to see that this particular patient population is being addressed because I think EO Melby had indicated that this is a hugely studied population. There isn't a lot of information out there. There's no research really to indicate that this is a population that really needs attention. So if this bill were to pass, I think it would really draw attention, allow for greater research and better level of care for this particular population. So I like to see this.
As Laura said, there was actually, I think recently the first informational hearing on menopausal issues that was just held, I want to say a week or two ago. So there is some interest in diving deeper, as you guys were saying.
Board Member David Lawler. Did you have your hand up?
I did, but I was just thinking there was a great great broadcast on that on NPR last night on menopause and mental health. Yeah, based on what everyone said, can we just take no position then? Because opposed seems pretty aggressive at this stage. Can I just move no position?
Okay, do we have a second?
I'll second it.
So we're going to count Tricia or Dolores as the second. Dolores, okay.
Okay. We have a first and a second. BRN moderator, can you take us out to public comment, please?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired and will move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Board President Trujillo, there are no public requests for comments on the WebEx. Are there any public requests for comments there in Sacramento?
There are no requests for comment here.
Thank you. Would you like me to close this window?
Yes, please. All right, we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan, yes.
Board Member Jovita Dominguez.
Jovita Dominguez, yes.
Board Member Patricia Nguyen.
Win, yes.
Board Member David Lawler.
David, yes.
Board Member Allison Cormack.
Cormac, no.
Board Member Vicky Granowitz.
Granowitz, yes.
Board Member Neela Patel.
Patel, no.
Okay. Motion carries. Can we go on to the next agenda?
So the next bill is AB 2442 by Assemblymember Zabur. And so again, a little bit of background on what processes currently are. Under current law, all boards within the Department of Consumer Affairs are required to expedite the licensure process for the following individuals. An applicant that has served as an active duty member of the armed forces and was honorably discharged. An applicant that is an active duty member of the armed forces and is enrolled in the Department of Defense Skill Bridge program. An applicant that is married to or in a legal union with an active duty member of the armed forces who is assigned to a duty station in California under official active duty military orders, and an applicant that has been admitted to the U.S. as a refugee, has been granted asylum, or has a special immigrant visa. And then current law also requires the medical board, the osteopathic medical board, the Board of Registered Nursing, and the Physician Assistant Board to expedite the licensure process of an applicant who can demonstrate that they intend to provide abortions within the scope of practice of their license. So this bill, AB 2442, is very similar in language to the provision we currently have around provision of abortion services. The bill would require the Medical Board of California, the Osteopathic Medical Board of California, the Board of Registered Nursing, and the Physician Assistant Board to expedite the licensure process for an applicant who demonstrates that they intend to provide gender-affirming healthcare or gender-affirming mental health care services within the scope of practice of their license. Answer any questions.
Board Member Mary Fagan.
Can you remind me, Lori, this is probably a question for you. When we do expedited license review, what is different in the process from a standard license?
So on the application, there would be a check mark that they would be requesting an expedite, and then they're required to submit the documentation. When licensing pulls that report on a daily, they pull it based on that expedite request. They go to the front of the line. Process-wise, that sounds great on paper. What that does tend to do is give them another area of possible deficiency. Because if they are not turning in that documentation to support why they are asking to be expedited, that's a deficient document. And then they do not have a full complete application. And so those do become problematic. However, at that point, our licensing team does go ahead and review the application. And if they are able to be licensed, they will license them. This, because it doesn't include a fee waiver, would not have a negative effect. If they were to include a fee waiver, then we would have to not process because we'd have to wait for the documentation to show that the fee was not required. Because if the documentation was not received, then the fee would be required and we would have to wait until fee was paid in order to process. So it's a convoluted process. And with so many expedites, you kind of start to wonder, does this help? Pulling them to the front of the line to do this. And so right now with this not including a fee waiver, it's something that we can implement. It would help it, even if it is determined that they would be deficient in that document. If it has a complete application, we would go ahead and process it at that point. We would not kick it back out.
But it still includes all the same background check.
Everything.
Okay.
Mhm.
Board Member Vicky Granowitz.
How, are there any timeframes in which they would have to continue to provide services to this population? Because with all these other examples, it's like those are people that are coming from the military who've probably been in other places. And so there's reasons to expedite them. But these are not necessarily people that have worked in the military, and so their paperwork is, you know what I'm saying?
I think I do, but I'll provide a couple areas of clarification. With the Federal Military Portability Act, it's almost null and void anymore because you don't have to be licensed in California. So the ones that we were expediting, they now can come in based on that Military Portability Act, and they do not need to have a license in California to work. They do, we will still expedite them. The one that is a call out is the abortive services. And so that is not tied to a military or a special visa or an immigrant or anything at that point. It is just coming in to provide abortive services. What it says in most of the documents and when we go to implement is that they provide a letter from an employer that they have a job offer. It's not even that they've accepted a job offer. And there is nothing in the law that I was able to see, and correct me if I'm wrong, Marissa, if it says that you must commit to a 6-month or a 1 year or anything to do that. It's just that you're coming in to provide and you stay. Now, that may sound like a reason to maybe not support, but typically you find if you look at studies of workforce that if this is a job that you've been providing, it's a job that you will probably continue to do and continue to do that. So even if they're have a job offer at hospital A or facility A or clinic A, they may still provide those same services if they choose to go with clinic B, because that is what their specialty is. And nurses and practitioners tend to stay in their specialty lines for many, many years.
And just for this bill to clarify, they do have to indicate that they have accepted employment or entered into a contract. And they have to have the applicant's starting date and the location where they'll be providing the services. But Lori's right, there's no time duration that is currently specified.
Board Member Patricia Nguyen.
Thank you. I'm wondering if we do decide to support this bill, if we would ask for an amendment that people who are granted this expedited process agree to stay, in this area for a certain amount of time, 2 years or something.
I think one of the issues that I think I would caution around that becomes employment law, right? And when you say you must stay at a facility or must be part of this, I think that really oversteps kind of our licensing role and our education and discipline, and it pulls us into a different realm. So I understand the intent of that, but I worry that that kind of blurs the areas of our jurisdiction. But again, if you go back and you pull the data and you look at workforce, nurses tend to be specialty oriented as well as the providers of practice. And so taking an example of a certified nurse midwife, you're going to practice as a certified nurse midwife. They do provide gender affirming care. And so wherever they work as a nurse midwife, they're going to have that ability to provide that care. When you're looking at nurse practitioners, they are educated specific to specialty. And that is, again, what their national certification is. And so if you have a psych mental health nurse practitioner, that is what they're educated for. That's what their national certification is. And that's where they're competent to practice in. You do see on occasion that you will have a nurse practitioner that's educated, but they're working in another area, specialty, and that does occur. But again, it's based on competence. And when you're competent in something, you kind of tend to stay there. So I don't know that it would be necessary for us to put in that clause because just the kind of the nature of the way that healthcare works.
Board Member Mary Fagan and then Board Member Allison Cormack.
Marissa, I recall, I think that we did support the bill for expediting the abortion services, correct?
Yes.
Okay.
I'll move that we support this bill.
Second?
I'll second.
Okay, we have a first and second of support on the floor. Can we open it up for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Board President Trujillo, there are no public requests for comments on the WebEx. Are there any public requests for comments there in Sacramento?
No, there is not.
Thank you. Would you like me to close this window?
Yes, please. Thank you. Okay, we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan, yes.
Board Member Jovita Dominguez.
Jovita Dominguez, yes.
Board Member Patricia Nguyen.
Win, yes.
Board Member Vicky Granowitz.
Granowitz, no.
Board Member David Lawler.
David, yes.
Board Member Allison Cormack.
Cormack, yes.
Board Member Neelu Patel.
Patel, yes.
Okay, motion carries.
Before we move on to the next agenda item, I did have board staff ask that when you do a motion, if you could say Trujillo makes a motion or Nguyen makes a motion, and then when you second, if you would state your name as well, just for our note takers. Thank you.
All right, thank you, Lori.
Okay, so the next bill is Assembly Bill 2471 by Assemblymember Patterson. This bill was also suggested by the board, and a little bit of background on how the system is currently set up. Currently, a public health nurse must apply and pay a $100, excuse me, you have a cold coming, $190 fee to renew their RN license, as well as apply and pay a $125 fee to renew their PHN certificate, so their public health nurse certificate. The PHN renewal requirement and associated fee were established in 2018 and set up to somewhat mirror the certificate renewal requirements and fees for advanced practice registered nurses. However, APRNs such as nurse practitioners, certified nurse midwives, et cetera, have an expanded scope of practice, and that expanded scope of practice can incur additional investigation and enforcement costs for the board. And so these additional costs are covered by that certificate renewal fee. So while public health nurses do have to complete specialized coursework and they have to do certain clinical experience to obtain the certificate, they don't have an expanded scope of practice beyond that of just an RN. So they would not have that same need for a renewal application and fee. So actually in the 2023 state budget, It was established the Public Health Nurse Certification Fee Waiver Program, which provided a one-time waiver of the initial application fee up until 2025, and then a one-time waiver of the renewal application fee up until 2026. And so this bill would somewhat codify the second half of the current waiver program that's in place by removing the renewal process altogether. The bill would indefinitely remove the requirement for public health nurses to renew their public health nurse certificates on a biennial basis. Happy to answer any questions.
I'll elaborate a little bit further on this. When we went in front of the sunset process, we asked for a removal of all the fee floors for each one of our license types so that we can work to address our budget. It was missed because it was a separate section within our Business and Professions Code to ask for a removal of the fee floor for the public health nurse. And so that stayed. So when we started looking at doing a cleanup process, they ask each year, is there a cleanup process? It was looked at, can we remove at least the fee floor of the public health nurse so that we can lower that down. But then there was another law that was put into place where HCI came in and they are paying for the renewal fees for all of our public health nurses and for initial and renewal that started January 1. And Allison asked where that was on the budget line this year and why that is new. And for more background, the public health nurse did not have to pay a renewal fee historically until 2017, when there was fee alignments kind of first time in a long time for BRN, where then it was requested to increase the fee to obtain a public health nurse, as well as add a renewal fee to that. And so this revenue source or this license kind of renewal fee has only been in place for a few years. That was met with a lot of opposition from our public health nurses. And as you can see, with HCI jumping in and providing a waiver for this fee, it was a deterrent and a hindrance for them to seek this certification, maintain this certification, and therefore be eligible for employment. So we did ask that this be something that addressed, and the member did bring it forward to do this for us to remove that. This is also in it would be supported by our current regulation. We would not have to do a regulatory change on this, except for in 1417, which outlines all of our fees, which we'll be moving forward with anyways, because we do have in 16 CCR 1490, it says under B, a public health nurse certificate shall remain valid as long as the person's license to practice as a registered nurse in California is active. And so that does help us with that provision as well, so that if we do get this and it does go through and it removes this fee, then they would not have to do a renewal for a public health nurse certificate.
Vice President Mary Fagan.
I'd like to move that we take a position to support this bill.
Cormac, second.
Motion from Mary Fagan on the floor and a second from David Lawler. Thank you. BRN moderator, please take us out to public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Board President Trujillo, there are no public requests for comments on the WebEx. Are there any public requests for comments there in Sacramento?
There are no requests for public comment here.
Thank you. Would you like me to close this window?
Yes, please. All right, we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Yes.
Board Member Jovita Dominguez.
Jovita Dominguez, yes.
Board Member Patricia Nguyen.
Win, yes.
Board Member David Lawler.
David, yes.
Board Member Vicky Granowitz.
Granowitz, yes.
Board Member Allison Cormack.
Cormac, yes.
And Board Member Neelu Patel.
Patel, yes.
All right. Thank you.
Okay, so our next bill is Assembly Bill 2532 by Assemblymember Mathis. Quick background again, this focuses on the California community colleges, which are an open access system, and they accept 100% of applicants. However, just because they're open access does not mean that all the courses are always readily available. So they do have several limited enrollment courses, such as nursing courses, that have limited enrollment capacity due to a variety of reasons, such as the teaching method or limited qualified faculty, which we've heard from our ADN programs. So signed in 2007, AB 1559 authorized community colleges to use a multi-criteria screening measure, a random selection, or a process blending the two if it determines that the number of applicants to a registered nursing program exceeds its capacity. So this bill would add on a criteria, and it would add residing within a medically underserved area to the list of life experiences or special circumstances that an applicant has that can be considered if a community college nursing program chooses to use the multi-criteria screening process. The bill would also extend operation of provisions related to admission to community college nursing programs until January 1, 2030. Happy to answer any questions.
Board Member Allison Cormack.
What's the definition of a medically underserved area? Is there a standard that we use?
So this is another bill that has one that's very similar, also listed, you
Right.
may have seen, and they actually point to two different definitions. This one, I know, one state, one's federal. This one points to the Health and Safety Code definition, which I will pull up right now, and I believe it's defined by HCI as well.
And perhaps, or should we consider 1183 at the same time, or?
If you'd like,
Up
you're
to the
more than
chair.
welcome to,
Okay.
yeah. So under, just here, it says, residing within a medically underserved area, as listed pursuant to section 124425 of the Health and Safety Code. And that section talks about the Primary Care Services Act and states that, let me make sure I have the right, I want to say the director, but I want to make sure I'm referencing the right department. Essentially, every 2 years, the director shall develop a list of underserved rural and urban areas and underserved population groups. The director shall take into consideration the list of urban and rural areas designated as medically underserved by the California Healthcare Workforce Policy Commission and by the Office and federal medically underserved areas and population groups designated by federal agencies.
So this one's a combo. It's sort of the California including the federal. Right,
Correct.
and then applying some more. Okay. That's helpful. Thank you. I guess now just another question. Do we know how many community colleges currently use the multi-criteria screening process for nursing?
Off the top of my head, I don't.
I don't have the exact number, but it is used by many.
Yeah.
Okay.
It's very, very common because I can tell you there's not a single community college that receives just the amount of applicants for their enrollment. So they do multiple levels of screening at various places, but within the community college, they do use the multi-criteria screening. And so I would, even if I had to look at it kind of and deduct down, I would say 100%, but I just don't have that number
Okay.
affirmatively. BRN, our nursing education consultants, when they do school visits, they don't necessarily look at their admission criteria because that is set outside of our Nursing Practice Act. We are aware of it, we're familiar with it, and we do look at admission criteria only if there is a problem, because that is when we start to kind of look in, okay, what are the criteria of the people that are coming in to be enrolled? Are you doing supportive services from enrollment on? What kind of testing, what kind of services are offered? And so we get into kind of the resource aspect of that to support the
Right.
student through, but we don't get involved in who they're choosing to come in the program and how.
So has the BRN taken a position on a bill before that decides who gets into nursing school?
Not that I'm aware of.
Okay, so that's something for us to reflect on in our decision. Thank you.
No question.
Board Member Neela Patel.
Melissa, not to get in the weeds of this, but how does this impact like the affirmative action bill that was passed federally? Like, does this have any opposition to it, I guess, or will it counteract it?
I don't believe so, because within the existing criteria, and I can pull it up, there's a list of life experiences or special circumstances that are already acceptable, and it includes such as disabilities, low family income, first generation of a family to attend college, need to work, so more kind of like they said, circumstances or marginalizing factors, and then this would add residing within a medically underserved area, so it doesn't necessarily call out. Yeah.
Any other questions or comments from the board? Would anyone like to make a motion?
David Lawler, I move to support this bill.
Patel seconds.
All right, we have a first from David Lawler and a second from Leela Patel. BRN moderator, please open it up for public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and will move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Board President Trujillo, there are no public requests for comments on the WebEx. Are there any public requests for comments there in Sacramento?
We have no requests for public comment here. in
Thank
Sacramento.
you. Would you like me to close this window?
Yes, please. Okay, we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan, yes.
Board Member Jovita Dominguez.
Jovita Dominguez, yes.
Board Member Patricia Nguyen.
Win, yes.
Board Member David Lawler.
David, yes.
Board Member Vicky Granowitz.
Granowitz, yes.
Board Member Allison Cormack.
Mac, yes.
And Board Member Neelu Patel.
Patel, yes.
All right, motion carries. At this time, we would like to take a bio break for 10 minutes, coming back
At 10:20.
at 10:20 approximately. Thank you. Good morning. We are back from our bio break. And Marissa?
Yes, all right. So only a couple more to go. This next bill is very similar to one we discussed already, AB 2581 by Assemblymember Mainshine. And it would require Healing Arts Board licensees to have the option of taking coursework on maternal mental health to satisfy continuing education requirements. That is the bill. Happy to answer any questions.
Any questions or comments from board members? Now, this is similar to his previous bill, correct?
Correct. It's just a different topic. Maternal mental health versus menopause and mental health.
Dolores.
Board Member Patricia Nguyen.
I would like, based on the same reasons from the last bill, I'd like to propose that we take no position on this bill at this time.
I second that, Mary Fagan.
Okay, we have a first on the table from Patricia Nguyen, and we have a second from Mary Fagan. Chair and moderator, can you take us out to public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Board President Trujillo, there are no public requests for comments on the WebEx. Are there any public requests for comments there in Sacramento?
There are no requests for public comment here.
Thank you. Would you like me to close this window?
Yes, please. All right, we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan,
Mary Fagan, yes.
Board Member Jovita Dominguez,
Jovita Dominguez, yes.
Board Member Patricia Nguyen,
Win, yes.
Board Member David Lawler,
David Lawler, yes.
Board Member Vicky Granowitz,
Granowitz, yes.
Board Member Allison Cormack,
Cormac, no.
Board Member Neelu Patel.
Patel, no.
Thank you. Motion carries. Thank,
Okay, so our next bill is Assembly Bill 2730 by Assemblymember Lackey. A little bit of quick background. Current law requires the California Office of Emergency Services to establish a protocol for the examination and treatment of victims of sexual assault and attempted sexual assault and the collection of evidence. The law also requires a qualified healthcare professional who conducts an examination for evidence of an assault or an attempted sexual assault to use the standard form and to make those observations and perform those tests required to record the data required by the form. So in 2019, AB 538 amended the definition of qualified healthcare professional to also include a licensed nurse practitioner or a physician assistant who is working in consultation with a physician and surgeon and who conducts examination or provides treatment in a general acute care hospital or in a physician and surgeon's office. So this bill would further revise the definition of qualified healthcare professional for the purposes of providing an examination for evidence or sexual assault to also include a licensed nurse midwife who is working in consultation with a licensed physician and surgeon. The bill would also remove the requirement that the consulting physician and surgeon conduct examinations or provide treatment in a general acute care hospital or in a physician and surgeon's office. And the bill would no longer require a physician assistant to work in consultation at all with a physician and surgeon when conducting an examination for evidence of a sexual assault. Happy to answer any questions.
Board Member Tricia Nguyen.
Thank you very much, Marissa. So when I went over this, and this is not, of course, my field of expertise, but I did wonder whether or not the exams done would kind of hold the same sway in court if there's not a doctor involved. Now, it's not because I minimize the importance of work that the specialty practice, medical professionals do, but I do wonder if it kind of minimizes the importance of these sexual assault exams. So I just am curious about that.
I'm actually a sexual assault nurse examiner by training, and I worked in that role from 2009 to, I believe, 2014. And so I'm only an RN. I do not have any advanced practice training. I don't have any other things. And I did provide testimony as an expert witness when the cases went to trial, and there was no question on whether or not you had physician involvement or such. So when looking at this law right now, I think it was a miss that they didn't include nurse midwives. one of the requirements of the training is to be able to be competent in speculum exams. And you have to do at least 100 of them in order to gain that competence. They have that hands down. So I think that it was a miss. It's a good kind of cleanup. The other aspect of this law is where you're removing that physician requirement. And that is in alignment with SB 1237 that passed a few years ago, as well as AB 890. And so I think this is more just a cleanup than it is anything that changes current scope.
Thank you very much. That is very helpful to me.
Any other board members for comments or questions? Board Member Vicky Granowitz?
You know, as somebody that worked with survivors of sexual assault, primarily children, I can tell you that this will make a world of difference. And it's a long time coming, so I would really urge people to support it. I just think it'll be amazing.
Are you making a motion to support?
I'm
Vicky?
making a motion to support.
Sounds great.
Win seconds.
Okay, we have a motion on the floor from Vicky Granowitz and a second from Patricia Nguyen. BRN moderator, can you please open it up for public comment?
We will be open for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Board President Trujillo, there are no public requests for comments on the WebEx. Are there any public requests for comments there in Sacramento?
There are no requests for comments here.
Thank you. Would you like me to close this window?
Yes, please. All right, we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan,
Mary Fagan, yes.
Board Member Jovita Dominguez,
Jovita Dominguez, yes.
Board Member Patricia Nguyen,
Win, yes.
Board Member David Lawler,
David Lawler, yes.
Board Member Vicky Granowitz,
Granowitz, yes.
Board Member Allison Cormack,
Cormac, yes.
and Board Member Neelu Patel.
Patel, yes.
Thank you.
So we'll skip over SB 895 because we addressed that yesterday. And then the next one will be Senate Bill 1015 by Senator Cortese. So a little bit of quick background. In 2019, the California State Auditor conducted an audit of the board's oversight of pre-licensure nursing programs. And during this process, CSA, or the California State Auditor, found the board did not have information about clinical placement spots that they needed when making enrollment decisions. So based on this finding, the state auditor included a recommendation for the board to essentially approve upon its data collection in this area. So what this bill would do is it would require the board to annually collect, analyze, and report information related to the management of clinical placements and coordination with clinical facilities by approved schools of nursing or nursing programs. The report must include information relating to how approved schools of nursing or nursing programs collaborate and coordinate with other approved schools of nursing, nursing programs, or regional planning consortiums that utilize the same clinical facility. The bill would require the board to publish the report on its website and submit it to the legislature on an annual basis. The bill would also require the board's Nursing Education and Workforce Advisory Committee, or NEWAC, to study and recommend standards regarding how approved schools of nursing or nursing programs should manage or coordinate clinical placements. It would require the study to include at a minimum the following topics: the maintenance of clinical education standards across approved schools of nursing or nursing programs, the participation of approved schools of nursing or nursing programs in consortiums with other nursing programs to manage or coordinate clinical placements, the necessity and feasibility of a statewide consortium or regional consortiums under the regulatory oversight of the board to manage or coordinate clinical placements of approved schools of nursing or nursing programs, Identifying and reporting violations of section 2786.4, which references the prohibition on pay to play for clinical placements. Ensuring fair and equitable access to clinical placement among approved schools of nursing or nursing programs. Identifying necessary information for the board to collect to ensure that approved schools of nursing comply with standards recommended by the committee. And the bill would also require the committee to submit a report to the legislature detailing its findings and its recommendations. Happy to answer any questions.
Any board member, Neela Patel?
I have a question for EOMLB. Do we have the bandwidth for this?
We actually do.
Okay.
Surprising. And so we actually met with the author and worked with them to make this a no fiscal impact bill. Because they were, asking what can we do? And because when it was first kind of put in front of us, we're like, I'll need more positions, I'll need this. And so this was a compromise. NEWAC right now, they meet a couple times a year. They are an advisory committee. They do have subcommittees out there. This could be a focus of a subcommittee or many. There is no timeline for this, which is great as well. So they can work through. It also aligns with some of the subcommittees that are already formed, but it does require a specific report, very much so similar to like our sunset bill that said they would focus on simulation. And so this just gives that work group a focus. And so that is something that we can do. When you look down at the data collection, we collect this data already. And it would just kind of expand some of that and allow us to coordinate that more and get this published out to our website.
Thank you. I make a motion. Am I jumping the gun?
Go ahead.
Mary.
Oh, I'm sorry, one more. Board member Mary Fagan.
This, if I'm reading it correctly, this bill would require clinical facilities to report clinical placement slot availability, as well as schools to report the clinical spots that they are requesting or needing. Is that correct?
That's the next bill.
Was that a separate bill?
Yeah, there is a separate bill. So part of this data collection, we do ask through the schools what the clinical capacity is for the site that they're asking to be approved. And so that might be what you're looking at. So we
Okay,
currently
it
use
says
a form.
Capture the annual capacity estimates from clinical facilities. So
Yes.
That's
Oh.
through the schools.
That is through the schools. So
Okay.
this is a current practice already in place from the California State Auditor. We have this form that people lovingly refer to as the EDPP 18. I'm sure you guys have heard that in public comment a couple times. And with that form, on that form that's utilized to help the NECs gather the data that they need to satisfy the requirements in 16 CCR 1427 so that they can approve a clinical facility, it asks for information on what your capacity is. The reason, and we'll go probably more into it in the next bill, why the school asked for that is to ensure that those clinical objectives can be met by utilizing that facility. If they've got a clinical group that says it's 10 nursing students coming in and they're in a pediatric unit that is 10 beds, on paper, that looks great. Well, we additionally go out and say, what's your average census? Because a pediatric unit at a hospital site that's not children's based might have an average daily census of 2. Well, if you've got 10 students coming in and you have an average daily census of 2, that may not be an appropriate placement for that school to utilize. And so when we are tasked in 1427 to make sure that the objectives of that program can be met through that clinical placement, that's data that the NEC has to have to be able to make that decision. So this is current process. It's nothing different. And we do get that information by working with the clinical liaisons at the hospital settings when they fill out and sign the form for the schools to turn in to us to get approved.
And the other piece that I noticed on here that it seems is different is that it would immediately discontinue the practice of having the program seek statements of support. Does those seem sort of arbitrary or maybe challenging for some programs to get, or if they don't have it, they may be trying to get it, but they haven't been able to do it just because they're not in charge of it. So I
Yeah,
like
so-
that, actually.
So with that, that's actually kind of wrapping up one of the recommendations from the California State Audit. When we were given that recommendation in June of 2020, it said immediately cease because that was a request that our previous board had asked of NECs to do. When they were trying to tackle the problem of clinical placements and growth, the board was asking for the nursing programs to send a letter out or an email or a notification out to all schools in the area and let them know that they were planning an enrollment increase and get positions of support or denial. And then they would turn in a table that says, I contacted this many students in this many academic programs in my area. This many did not respond. This one were in favor and this one were not. And again, when that was first implemented, we were getting amazing feedback and the board was making decisions based on that because it seemed to be fairly equitable. We started receiving complaints saying that colleges and universities were pairing up and they were saying that it was not going to have an impact because maybe it was a sister college or they had some financial agreement or they were all kind of tax identified the same, et cetera, et cetera. And so it became more of a he said, she said. The board then asked for the NECs to make phone calls to the hospital settings or the clinical facilities to get accurate information, and that became problematic. So when CSA came through and looked at all of that, they said, just stop immediately. So we did cease practice on this in 2020. We have not been doing that since.
Although haven't we asked recently some programs to come back and have other programs within their vicinity make some comment and public comment about whether or not it would impact them? We've done that, haven't we?
The most recent one was to work with consortiums, not to work with individual schools. And so the consortium is more of a neutral player where they would coordinate the efforts through that. And so that is different than going school to school.
Okay.
Any other requests for questions or comments from board members?
I make a motion to support SB 1015.
That was Neelu Patel makes the motion.
And this is Dolores Trujillo, and I second that motion. BRM moderator, can you please take us out to public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in the request for comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, I would like to make a comment. Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, I would like to make a comment. Mari Lopez would like to make a comment. 1 second, please. Go ahead.
Thank you. Good morning, everyone. My name is Mari Lopez with the California Nurses Association. Thank you so very much for this discussion today. CNA is a proud sponsor of SB 1015, and we strongly encourage the BRN support today. 1015 would ensure, SB 1015 would ensure transparency on clinical placements and start the process of developing BRN standards to address clinical impaction. Specifically, the bill would provide explicit statutory authority for the board to collect, analyze, and report information on how nursing programs manage and coordinate clinical placements. And it would have NUAC study and recommend standards on fair and equitable access to clinical placements. Importantly, NUAC would examine whether a statewide consortium would help the BRN in creating clinical placement guardrails. We urge your support on SB 1015 to ensure that you have statutory tools necessary to start addressing the issue of clinical impaction head on. Thank you.
Thank you for your comment. Board President Trujillo, there are no other public requests for comments on the WebEx. Are there any public requests for comments there in Sacramento?
No, there are no other requests for comments here.
Thank you. Would you like me to close this window?
Yes, please. All right, we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan, yes.
Board Member Jovita Dominguez.
Jovita Dominguez, yes.
Board Member Patricia Nguyen,
Win, yes.
Board Member David Lawler,
David Lawler, yes.
Board Member Vicky Granowitz,
Granowitz, yes.
Board Member Allison Cormack,
Cormac, yes.
and Board Member Neelu Patel.
Patel, yes.
All right, thank you.
So the next bill is Senate Bill 1042 by Senator Roth, and it is somewhat similar in desired outcome, but a little bit different in kind of approach and what would be required. So the bill would require a health facility that offers pre-licensure clinical placement slots to, upon the request of an approved school of nursing or an approved nursing program, and regardless of whether the school is public or private, meet with representatives from the school or program to discuss the clinical placement needs of the school or program. And then the bill goes into kind of clinical placement data from both sides, the nursing program as well as the health facilities. For the approved nursing programs, the bill would require by March 1st of each year, an approved school of nursing or an approved nursing program to report to the board and HCI the following information: the beginning and end dates of the academic term for each clinical slot needed by a clinical group with content area and education level, and the number of clinical slots that the school or program has been unable to fill. And then on the health facility side, it would require health facilities to report to HCI or the Department of Healthcare Access and Information the following information: estimated number of days and shifts available for student use for each type of licensed bed or unit, number of days and shifts being utilized for student use for each type of licensed bed or unit, name of the academic institution with an approved school of nursing or nursing program utilizing each type of licensed bed or unit, average daily patient census per type of licensed bed or unit, and average daily number of registered nurses staffing each type of licensed bed or unit. The bill would then require the board and HCI to use the data to work together to meet the clinical placement needs of all approved schools of nursing or approved nursing programs, regardless of whether the school is public or private, by conferring with the health facilities within the appropriate geographic region of each school or program in an attempt to match available clinical placement slots with needed slots and to create additional clinical placement slots to meet school or program demands. The bill would require the board and HCI in meeting the clinical placement needs to prioritize the clinical placement needs of the approved schools of nursing or approved nursing programs of community colleges and the California State University campuses. The bill states that if a health facility cannot provide additional slots, the health facility shall provide HCI with written justification of its lack of capability or capacity within 30 days. Lastly, the bill would require HCI, in collaboration with the board, to notify the health facility within 30 days of its acceptance or rejection of the health facility's justification. And we have also been working with the author's office on this language, so we anticipate some changes coming in the future, but we're not exactly sure of the language quite yet.
Any questions or comments from board members? Vice President Mary Vega.
Has there been any, and I don't see it in here, so perhaps there hasn't, but any comment or feedback from the California Hospital Association? I just want to, I know this adds additional reporting on the hospitals. It'd be good to hear from the facilities. They think that what type of a burden this would create.
And on record yet that I'm aware of formally, because when they would submit their support or opposed letters, it'd be to the committee and that would be reflected in the committee analysis. But since we're just kind of coming up along the time when policy committee hearings are getting up and running, there's nothing that has them officially for or against that I could quote, factually.
So this is a similar bill to what was put forth last year by Lowe. And we worked with them on this language, on that reporting. And one of the big things that we took into consideration was the impact on the hospitals with that. And so the hospitals are required to report, and you could see on that bill, so let me just click on it here real quick, that data is actually part of a report that is already completed. And it's the hospital discharge abstract data record that includes all the following. So that's a report that the hospitals complete, I believe it was every 6 months. And so these were just those additional questions added to that report. So it would not be an additional report or an additional kind of task to take on. It would just be a few extra data collection points. Because we did not want it to be a lot of extra work or a separate report that would have to come in. That was also why when we were kind of going through providing feedback on that bill last session was they wanted the BRN to collect. And I was like, more data that we have to collect. I don't know that we have the bandwidth for that. And I said, so the hospitals already report to HCI. Why don't we just keep that consistent? And HCI really does an amazing job at collecting data and analyzing it and reporting it out. So that helped to kind of maintain that. When we were working through this process last year with the other bill, California Hospital Association had just kind of stayed neutral at that point. And so we'll see if that changes. We haven't had a lot. I have met with some of them asking the questions and kind of working through kind of talking points, because what they wanted to know is, would this be helpful for us? And it absolutely would be helpful for the BRN. This is data collection that we've been missing for our board and just for the public to put out there, is we know the N of our schools. We know how many pre-licensure nursing programs we have. We know how many our enrollments are, and we know what they need for clinicals. What we don't know is what is available for clinicals. And it's not just that the site is there, it's the appropriateness of that. And so kind of the similar conversation to the last bill that we discussed is you might have a 10-bed unit that you would think that would hold 10 students, but if your average daily census is 3, it doesn't. And that's data that absolutely has to be reported. The other item that comes in there is, why is it important to know how many RNs are on the unit? As you progress through some of the nursing programs change the way that they place their clinicals. And early fundamentals of clinical role, they might do a 1 student to 1 patient assignment. But as you're going and moving towards graduation, those schools will place a student with a nurse. And so that is how they're doing that clinical, because then they're able to take a full patient load. And they're able to be more aptly prepared to take a full patient load when they're employed. And so that's why that information is key to have. We have, again, this is information that is requested out on the EDPP 18. When schools have let us know, there are some hospital sites, some clinical facility sites that are refusing to give the information and refusing to sign. And therefore, it's very difficult at that point for the nursing education consultant to do the review and say, yes, it meets 1427, we can approve this. So this would absolutely help the BRN and help academic institutions. Lowe's bill last year had like a fine that was associated with that. And so we worked on the variance process and having them report out because as we know, there are many times where a hospital will close a unit to go through a remodel, or if a hospital is really low on staffing, the majority of their staff is travelers. And if that is occurring, that's not a site that you want to use for students. And so that might be where they say, you know, this semester we will not be able to take these students. And so it's not punitive, it's just fill out the variance so we know why that's not occurring.
Yeah, one of the things I mean, from a BRN perspective and trying to make determinations about enrollment changes, this information would be invaluable.
Yes.
But I also know from, 35 years as a hospital administrator that they can be very subjective.
Yes.
What the availability is, either because of what you said, census changes or construction or whatever, or just this unit prefers not to take students. So I think it would also be helpful at some point, and I don't know if there is something out there with the National Councils of State Board of Nursing or some other, to say what should a rule of thumb be for what capacity should be in a facility. I know in our instance, we were like, we can't take any more. And then there was, okay, yeah, we can take a few more, and they had fine experiences. So it's not black and white.
It's not. And National Council of State Boards of Nursing typically look at it from a board of registered nursing perspective and not from a hospital association perspective. So they wouldn't have a lot of that information. And so this is really just starting to kind of come out to see how we can manage this. Nevada has a statewide consortium. And so that statewide consortium is overseen by the board. It used to be managed by the board, and that became too much. And so now they moved that out to a private sector company that manages it, but the board oversees that. Louisiana goes so far as that board makes all the clinical placements. And so again, it's that every board of nursing throughout the nation is different and have different academic oversight, different focus. And I think this is a good kind of landing point for us where it's just data collection through an entity that they already utilize through a report that's already done so that we can start to get the information to publish it out and share.
Just one last comment. I'm very interested in seeing what the hospital association sees of these changes, though. I mean, I'd be certainly willing to support it or whatever, but I'm going to pay attention to the feedback from the hospital association and as this moves forward.
Yeah, it's very key to work with the partners.
Board Member Patricia Nguyen.
Yeah, thank you very much. I agree with Mary. This is going to allow us to make decisions that are more precise than looking at a map and saying, oh, there's an impacted area. Now what do we do? Well, maybe if we just reduce it down a little bit, we'll feel comfortable. So I am completely in support of this bill. I think it's going to allow all of us to do our jobs better.
I think this bill, along with the BRN bill for faculty, where we can get accurate numbers and stuff on that, I think it's going to change the way that we look at data.
Board Member Ellison Cormack.
Thank you, Chair Trujillo. So I just want to be sure I understand on the data. Currently, when we make a decision, we only have sort of point in time data and this would be ongoing, meaning it would be updated and potentially changes would be made during programs to rearrange.
Changes are made during programs to rearrange at all times. In 16 CCR 1427, there's a clause in there that has the schools report within 30 days any changes. And so similarly in this bill, there was the mention that there would be a change that they would do any reporting within 30 days. But with the hospital side, it's in every 6 months. And so we'll get the information from the school and then that data would be validated on a 6-month basis because it is fluid. Every week it could change. Students are moved in and out of clinical. If a surveyor shows up, students are moved in and out of clinicals. Again, if there's maybe some damage like a water leak or something that occurs. And so those are the ones that we get reported by our schools that said, hey, we've been displaced. This is the reason why. Can you help us? This would help validate that data that comes from the schools by validating it on every 6-month basis through that report.
And it's the nursing education consultants who manage that when that comes in?
So nursing education consultants manage the academic side of that. And so they are assigned to individual schools. They have about a 30 school capacity right now. And the board of the director of that nursing program contacts the NEC to let them know, hey, we lost our clinical placements, or I need approval of a new one because we lost our clinical placements. And that is current NEC role.
Okay.
This additional data collection lives with HCI, not with us.
That's, yeah, that was, okay.
And so we would gather that. It would go into our data bank that we're building separate with DCA's OIS. And that will be published out, again, separate from the NECs, but reports can be pulled by anybody.
Okay. And then my larger question is there's it looks like a very neutral paragraph, but it says that it would require the board to prioritize community colleges and CSU campuses. So I'm not yet a year on the board, but my understanding is that it would be appropriate, and we have traditionally been neutral as to whether or not a nursing program is publicly financed or privately financed. So I'd be interested in understanding from legal staff and the executive officer and our legislative affairs person, if we should be taking a position on prioritizing public over private or vice versa, or, this seems like a very big policy issue. So I'd like us to have an open discussion on that.
One of the things I think Marissa is going to say is that we're in consult with the author on working through that language.
Well, and also one thing that is in this bill now that is a little bit different that I think would change why this provision has never come into play before is that technically how the bill is currently written, it would charge us an HCI with doing that matching, which currently we don't do at the state level. It's done at the local level. We're in conversations around, rather than being the upfront matcher, maybe coming in with technical assistance and really letting the local partnerships work themselves out. So we've never been in a place where we could prioritize, because we don't actually do the matching as we're currently set up. Locally, the health facilities and nursing programs work together on that.
Okay, that seems like a technical thing as opposed to the policy of which should be prioritized.
From a, I mean, I can let Reza go in. I know I've seen in, I can't speak to the nursing board's history. I've seen in systems in past, certain entities, certain systems be prioritized in certain ways via legislation. I think if it's in the statute, that gives authority. Whether or not it's something the board agrees with is completely up to the board's discretion.
And then this is very similar to what was introduced last legislative session through Lowe, but it was only focused on community college. And so Roth has extended it out to include private colleges and universities as well.
No, not private.
The data collection.
Correct.
Yeah, I'm not talking about the data
Yeah.
collection. I'm talking about the clinical
So
placement.
he's done that so far, but I think what's really going to happen is when we see the new language that comes out, which we're working on, which pulls BRN out of that role of matching. That was something that we had asked to be pulled out of and let that handle at the local levels and with HCI, and us only come in at the end to do what we currently do, which is to help facilitate placements if there is an issue. But that language is not out yet.
Okay. Any thoughts from our legal counsel on this policy issue?
Just that, I mean, it's understandable that it's kind of eye-catching, because you're right. Historically, this board has been neutral and not really given any different treatment to schools that are community colleges versus private, for-profit, et cetera. So that's how the board has applied its enrollment decisions and really everything. But the law hasn't explicitly given us any reason to treat them differently or mandated that we do so in any kind of way. So operating under our current laws, we've never had any reason to give that kind of differential treatment. And so the appropriate position was to be kind of neutral on that. Here, it again, like I said, it is kind of eye-catching a little bit. I haven't analyzed like if there's some kind of equal protection argument that the private schools would have under this. That's kind of more their the legislatures and the stakeholders purview to address that piece of it. So as long as it's in the legislation, I think you can leave it to the stakeholders to battle out the whether there is like a constitutional issue or some other legal ramification of that particular piece. The crux of this bill is the data collection, the reporting and whatnot. But that is a pretty significant piece, and I can see how it would raise your eyebrows a bit.
Okay, well, thank you very much for that. The most that I would be willing to support us taking a position on this would be watch based on that significant piece of information that is what we have available, which is different from private conversations that staff may have had. So that's how I'm approaching this particular bill at this time. Watch would be the maximum I'm willing to support.
I do want to give one more piece of information, and I know that with working with this similar bill last session and now this one, they were basing it on data collection that we had previously already shown. And that was when a few years ago, we started tracking the data of enrollment growth and how that played out. And there was a significant difference between private sector growth and public sector growth, with one one calendar year of having less than 100 growth in community college and over 1,000 growth in private sector. So there is data out there that shows that there is a disparity, and I could see why these bills started come through, that we're working on that. So I can pull that data for you really quick. It'll take me just 1 second here. It's loading. And I can go year by year, which is will help to kind of clear why I believe that provision was put into place. And so in 2023, just the year that closed right now, what the board approved in enrollment slots, so new student slots that went to schools in a public setting was 657. New student slots that went to schools in a private setting were 2,002. So you can see that there's a disparity. In 2022, new student slots were 207 that went to a public school setting, and private was 990. The prior year in 2021, new student slots went to public settings were 56. In a private setting were 1,313. Prior to that, in 2020, this is our COVID year, 18 student growth in public settings, 264 went to private. In 2019, 60 went to public. In 2019, 742 went to private. In 2018, which is as far back as the data collection went, when we started collecting and sharing, public school growth were 44. Private school growth was 144. And that is BRN board approved enrollment growth year by year. So you can see
Right.
that there is a disparity, and based on that data, I'm sure that's the data points that they were trying to address with this, because you
Yeah.
can't have growth without faculty or clinical placements.
Understood. I mean, in order to interpret these correctly, we would need to know the base. So we would need the base from 2017 to, presumably before we could identify that as truly a discrepancy. I don't know the numbers, but they could go either way if there was an enormous public, which I don't think was true. So I'm just saying the delta isn't enough.
A base, explain
What
you're.
is, so you're giving the deltas? What was the base? What was the number of students in private and public in 2018?
Okay.
Yeah.
I do
I mean,
have
you don't
that
have to
data.
give
I
it
don't
now.
have that right
You
now.
don't have to give it now, but just thinking, just the delta isn't enough to make a decision about whether or not something is appropriate or inappropriate.
Yeah.
Yeah.
Last year's data, I can give percentages. And 2 years ago data was reported out from UCSF when they gave the actual enrollment data, not growth, but
Right.
enrollment data, was 52% of our nursing students throughout the state were private colleges and university, and 48% were in community colleges and other state universities.
Okay, that's super helpful. Thank you.
Board Member David Lawler.
David Lawler, I move to support SB 1042.
Jovita seconds.
Okay, we have a motion by David Lawler and a second by Jovita Dominguez. BRN moderator, please take us out to public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give reminders as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Julie Van Houten would like to make a comment. 1 second, please. Go ahead.
Hi, I just want to say as a director of a community college, it really is heart-wrenching to see the students that we have to turn away because we don't have placements. And then you know that a lot of those students are now going to be paying a lot more in top dollar for their nursing education at the private sector. So I see I see it firsthand, you know, we can't expand because we don't have the clinical placements, yet these private community or private colleges are coming in and it's extremely expensive. It's probably 3 or 4 times what they're paying in the community college. If we could have support for the community college, I think that we could expand our programs and educate a lot more students, either, you know, at the community college level in a more economic fashion for the students of the state. Thank you.
Thank you for your comment. Board President Trujillo, there are no other public requests for comments on the WebEx. Are there any public requests for comments there in Sacramento?
No, there are not any requests for comments here in Sacramento.
Thank you. Would you like me to close this window?
Yes, please. All right, we're going to take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan, no.
Board Member Jovita Dominguez.
Jovita Dominguez, yes.
Board Member Patricia Nguyen.
Win, yes.
Board Member David Lawler.
David Lawler, yes.
Board Member Vicky Granowitz.
Granowitz, yes.
Board Member Allison Cormack.
Cormac, no.
Board Member Neelu Patel.
Patel, yes.
Thank you. Motion carries.
So there's only 2 more bills, both of which are similar to bills we have already discussed. So SB 1067, this is another bill around expediting licensure. The bill, or SB 1067 by Senator Smallwood Cuevas. I always want to identify the author. This bill would require healing arts boards under DCA to expedite the licensure process for an applicant who demonstrates that they intend to practice in a medically underserved area or serve a medically underserved population. The bill would authorize an applicant to demonstrate their intent to practice in a medically underserved area or serve a medically underserved population by providing proper documentation, including but not limited to a letter from an employer located in a medically underserved area or which serves a medically underserved population, indicating that the applicant has accepted employment and stating the start date. Happy to answer any questions.
Any questions or comments from the board? Board Member Patricia Nguyen.
Thank you very much. My concern on this one is the same as my concern on the last one, which is it's one thing to say that you're going to work in a underserved area and good for you, but I would love to see some kind of a commitment. And I do understand that that's, you know, hard to get, but this is not necessarily a practice. So EO Melby did say, you know, if you are going to do this kind of practice, you will stay, but this seems completely different to me.
Yeah, that's an area commitment versus a specialty commitment. So we would not have any, there's not a lot of data around that. There is some data that our nursing schools have shared with us where when they educate them in that area, they seek job placement in that area and they want to stay within the area that they live. So we could potentially extrapolate that data, but there is nothing that is firm that ties it together.
Board Member Vicky Granowitz.
Yeah, and I'm going to vote against this one for the same reason I voted against the other one, which is if we keep expediting programs. And I totally support what both are trying to do, but I think there's better ways to try to serve both of those programs. And I don't know how many programs we can expedite or populations we can expedite before it becomes moot. So
Board Member David Lawler.
I just wanted to comment, regardless of how the vote goes or your support or oppose the position, I'm surprised there is no data. It must just be anecdotal. I thought it was assumed people in underserving areas go to school in those areas and stay and get a job in those areas. They're not traveling out of those areas.
Some do, depending on wage And so what we did see a huge shift during COVID and immediately after COVID was the draw to the traveling nurse. And so we had people leaving facilities that they had been long-term employees at 10, 20 years, leaving because they were working next to a traveler nurse that was making $7,000 a week and they were making $1,000 a week. And so where they had normally been committed to, they left because that financial draw was there. And so that did start to change the environment of nursing and the way that work was done. And so that is also why we have some of the workforce challenges that we have right now, because people were leaving long-term stable jobs to go to the traveling positions. And some were taking travel jobs at the same hospital, they'd quit. And so they would quit their regular employment job and then come back as a traveler to that same unit, just making exponentially more. It was definitely interesting to live through that. So the data is a little bit different right now. We'll wait for something firm.
Vice President Mary Fagan.
You know, to me, just seeing these bills being introduced about expediting license is more of I think, a very strong message to us to fix the processes that we have in licensing that are delaying. I mean, it's just whether it's joining the compact, which I think will come up later, or looking at every single delay or needless step in the process so that we can fix it so many people are not struggling to get their license in California.
Definitely. And as you alluded to, there was a bill that was introduced for a compact. It did not meet our deadline for the agenda. So that will be discussed at our next board meeting. But just to kind of clarify process on that, we do need to continue to work on our endorsement applications that coming in from out of state. We're looking at leaning that process, looking to see what kind of requirements, documentation stuff is still needed to ensure the safety of California. One thing that when you're looking at this and trying to solve it, a compact seems to be at face value kind of a reasonable thing. But if you change your residence, you actually have to endorse into California. And so you would, because this becomes your state of residence. And so we still have to fix our endorsement process no matter what. Even if we join a compact, it's not going to fix our endorsement process. Additionally, when they do come in, if we enact a compact here in California, it creates two license type. You have a single state license and a multi-state license. So that would increase the workload within our licensing department, which may further slow that down until we can get that adequately staffed and built. So that said is not whether I'm a support or not support of a compact, but understanding that a compact is not going to fix our licensing issues. We do need to fix our endorsement process, period. And that is going to be by looking at what the standards are for licensing and what we absolutely need for primary source data and how we can streamline that process.
All right, any other questions or comments from the board? Anyone would like to make a motion? Okay. I would like to make a motion of watch. We can watch this and see where it goes.
I'll second. David Luller.
Thank you, David. BRN moderator, please take us out to public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated their question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Kathy Hughes would like to make a comment. 1 second, please. Go ahead.
Nurse and the executive director of the Nurse Alliance of SEIU California. We represent about 35,000 registered nurses across the state. We haven't taken official bills on many of the pieces of legislation yet, but one of the things we do look at is both medically underserved areas in the urban and rural areas. And we can say that our members who have gone through nursing programs are looking into going through nursing programs, are looking at working in the areas where they went to school. Expedited licensure is just addressing a population of nurses that are critically needed. They still have to go through all of the steps of being approved by the BRN. It's not like they are getting a pass on any of the requirements. And we would ask the board members to always look at every piece of legislation, as SEIU does, through a racial and economic justice lens. Thanks so much.
Thank you.
for
And
your
just for
comment.
some further information, Kathy, if the student is educated here in California, living here in California, and seeking license in California here, they would not come through our endorsement process. They would come through license by exam. And that process right now has been fully automated through our school systems. And there would not be an expedite that would be put towards that school. As soon as that school has conferred degrees, that program director logs into our portal, graduates them, and within 24 hours, that information is sent over to Pearson VUE. And 24 hours after Pearson VUE receives that, they send an email to that student and they get the authorization to test. It is a hands-off process within our board because the nursing education consultants have already reviewed the curriculum, they've approved the program directors, and we have it set to go forward in a very streamlined process. There is no wait time on that one, so there would not be an expedite. So just for some clarification, this expedite would strictly address those people that are endorsing into California for licensure coming from out of state.
Thank you for your comment. Um, I have in the chat or in the Q&A, somebody just posted in a thank you. Board President Trujillo, there are no other public requests for comments in the WebEx. Are there any public requests for comments there in Sacramento?
No, there are no requests for public comment here in Sacramento.
Thank you. Would you like me to close this window?
Yes, please. Okay, we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan,
Mary Fagan, no.
Board Member Jovita Dominguez,
Jovita Dominguez, yes.
Board Member Patricia Nguyen,
Win, yes.
Board Member David Lawler,
David Lawler, yes.
Board Member Vicky Granowitz,
Granowitz, yes.
Board Member Allison Cormack,
Cormac, yes.
and Board Member Neelu Patel.
Patel, yes.
Thank you.
So this is the last bill, and it is very similar, nearly identical to AB 2532, which we discussed earlier. This is Senate Bill 1183 by Senator Hurtado. The bill would add living in a medically underserved area to the list of life experiences or special circumstances of an applicant that can be considered if a community college nursing program chooses a multi-criteria screening process. The bill would also extend the operation of provisions relating to admission to community college nursing programs until January 1st, 2030. What I should have clarified in the last one is currently the law has them sunset as of January 1, 2025. So both of them would do that 5-year extension. The only difference with this bill is when they use the phrase medically underserved area, they cross-reference to the federal government, the Health Resources and Service Administration, using their data versus the Health and Safety Code, which, as we discussed, was a mix of the state and federal data.
Okay, Board Member Allison Cormack.
Thank you, Chair Trujillo. I'm glad we've had this wide variety of bills because it's clarified my thinking about how to approach them. And I just want to be clear on policies that I think would be supported by the public in the state of California versus the process part. So we've had bills that we've discussed about admission, licensing, and continuing education. And I just want to be clear that I'm voting against supporting ones with admission because I don't believe that is connected to our responsibilities. But ones that are related to licensing, especially endorsement, where we know we have a problem, I've been supporting, and continuing education the same. So I think any member of the public watching would be like, why is everyone going back and forth and yes and no? And there's a difference between supporting a policy objective and supporting an intervention in the process based on, our responsibility. So I just wanted to state that. And that's why I would not support this, because I don't believe that we should be taking positions on admission to programs that is not within our purview as I understand it.
Any other questions or comments from the board? No? All right, I would like to make a motion that we watch this bill. Do I have a second?
Jovita seconds.
Thank you, Jovita. BRM moderator, please take us out to public comment.
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in the request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment."
Board moderator, as we're waiting for public comment, can you please, oh, never mind. I see that you elevated Shannon Johnson. We will be taking 9.5 to finish up our board agenda. That was resequenced yesterday.
Thank you. Bell and Kirsten would like to make a comment. 1 second, please. Go ahead. Yes, go ahead.
Okay. I just want to say that I would like the board to support that we use the multi-criteria for underserved students, just because even though I have increased my enrollment with permission from the BRN, I still receive lots of applicants from outside of this area. And our local hospitals are training these students. And unfortunately, after they're trained, they leave the area. So that's all I have to say about it.
Thank you for your comment. Board President Trujillo, there are no other public requests for comments on the WebEx. Are there any public requests for comments there in Sacramento?
There are no public requests for comment here.
Thank you. Would you like me to close this window?
Yes, please. Okay, we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
No.
Board Member Jovita Dominguez.
Jovita Dominguez, yes.
Board Member Patricia Nguyen.
Win, yes.
Board Member David Lawler.
David Lawler, yes.
Board Member Vicky Granowitz.
Granowitz, no.
Board Member Allison Cormack.
Cormac, no.
Board Member Neelu Patel.
Patel, yes.
That carries. I think you had 3 no's.
5 to 3, yeah.
All right, thank you. Thank you, Marissa. At this time, we will go back to the agenda. Item 9.5, discussion and possible action, appointment of Intervention Evaluation Committee members. And this is the committee for Patricia Nguyen.
Thank you very much, Madam Chair. I'm going to turn this over to Shannon Johnson to present these 3 individuals.
Trisha. Hi, Shannon Johnson, Chief of the Enforcement Division, excuse me. And I will be presenting 9.5. 9.5 is a discussion possible action regarding the appointment of our Intervention Evaluation Committee members. Today, I have 3 for you. Rebecca Gastelum is a public member applicant for IEC 3. Darcy Hostetter Lewis is a nurse applicant for IEC 11, and Wade Murad is a physician applicant for IEC 12. These are all new appointments to our IECs, and should they be voted in today, their term expiration will be February 28th, 2028. And I would just like to call for a motion to approve.
Board Member Allison Cormack?
Ms. Johnson, could you please clarify our written information says June 30th, 2028 as term expiration?
I have on the agenda item summary 2/28/2028, so there may be a conflict. It is February 28th, 2028.
Okay, so the printed agenda was incorrect?
Apparently, yes, because it
Okay.
would be 4 years from the day today of when you vote them in. They're a 4-year term limit.
Today's the 29th, so did you want to change that since it's a leap year and it's a 4-year term to 2/29/2028?
We could change that. I anticipated redoing this yesterday, so we could change it
Fair
to
enough.
February,
Fair
from
enough.
February
Shall we give-
29th, 2028.
Shall we give them an extra day?
But,
2028? Okay, with,
It will be a leap year.
with that, yeah, right. With that
Yeah.
modification, I'm happy to move, this is Board Member Cormack, approval of the appointment of these 3 members of the IEC.
I second that. It's Mary Fagan.
Okay, we have a first and a second on the floor. BRN moderator, can you please open this up for public comment?
We will be opening for public comment now. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember you will have 2 minutes to make your comment. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired and will move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Board President Trujillo, there are no public requests for comments on the WebEx. Are there any public requests for comments there in Sacramento?
There are no public requests for comments here.
Thank you. Would you like me to close this window?
Yes, thank you. All right, we'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan, yes.
Board Member Jovita Dominguez.
Jovita Dominguez, yes.
Board Member Patricia Nguyen.
Win, yes.
Board Member David Lawler.
David, yes.
Board Member Vicky Granowitz.
Granowitz, yes.
Board Member Allison Cormack.
Cormack, yes.
And Board Member Neela Patel.
Patel, yes.
Thank you. And I believe that wraps up our agenda. We are going to go to.
Open session. It wraps up the.
It wraps up open session, yes. So at this point, we are going to convene in closed session. It's item 11.1.
Good afternoon. It is 3:29 and the board has concluded their closed session and we completed our agenda previously to our closed session and we are adjourning.